Obviously, it's not the doctor that you were expecting for today's presentation. So he's a good friend of mine. So today we are going to present some of his cases. So I have made a mixed presentation, so we can discuss about the prosthetic considerations and procedure for complete arch implants, supported restorations, and also fixed dental implants. Okay? So I hope that you have a nice week. We started with a cloudy day, so thank you for being here today. So we are going to talk about dental implants and fixed prostheses. Okay? So I know that all of you now you're dealing how to make provisionals right in your Thursday's lab and Friday's lab. So we are going to talk about a little bit how to connect those kind of presentations and work with dental implants. So of course, all of you did this practice, right? You put your dental implants last semester and you already did that practice, right? So we talk about a lot today. We will focus a lot in the prosto part and the dental implant part. But always, always you need to remember that the patient part is the most important one, right? Because you did the practice and you were putting your dental implants, you didn't have a surgical guide, completely analog. Dr. Juan and myself, we have decided that you just do it the way that you feel more comfortable, right? And the assistants will help you how to make the guidance, right? But all this model is not connected to anything. It will not heal, it will not have anything, okay? So what happens? Well, you put this dental implant, right? Now, you put it because Dr. Juan and myself and the company, those are the dental implants that they have, so we could do the practice. But are those dental implants the best size for that model? You have a length and you have a width and you have that dental implant. Were the right dental implants, or were they too big? Or were they too small? Now, when you were putting your dental implant, most of you were just drilling and you were not going in and out, so probably your bone got burned, right? And the other thing that happens to all of you, right? You put your model on the table. So there is a support that is holding you, so every time that you push, your model was just staying there. But of course, in your patients, that will not happen. You will have your patients, and every time that you will start drilling, that's something will just hold back. Okay, so now I will ask you the other thing. What type of dental implant is the one that you put last semester? Does anybody knows? Is that a bone level dental implant? Or a tissue level dental implant? Right? So you put a dental implant, there's a lot of type of dental implants. And that's the kind of things that we are going to talk about today, right? Some of your patients will have really specific type of characteristic. So the first thing that you need to know is to diagnose your patients. So in that way, you can choose the best dental implant that you can have. Because dental implants have been just created because every time that we say, oh, we have this kind of issue in the patients. So we go and we create a dental implant that can solve those problems. So of course we can achieve aesthetics and functions, right? So we can have longer dental implants. Nowadays are the most complex ones. Nowadays we have managed to do really well in surgical guide kind of dental implants. So these kind of dental implants, they are too long, and usually you will just use it in really old patients where the bone is completely reabsorbed. The other thing that we will have is, depending on the patients that we have, the amount of bone that we have, we can decide later on if we are going to have the prosthetics that we are going to do, if it's going to be fixed, if it's going to be just supported by like a hybrid prosthetic, right? Will be detachable or not? Will be abutment retained over denture? Will it have a locator or a ERA? So we are going to talk about all these kind of things. So the minimum difference in each patient can change the diagnostic. Because always, what we said for the last year, you always need to diagnose your patient, right? But nowadays, after one entire year of period education and training, Now you know that you need to diagnose, but also you need to know the stage and the change that your patient have. Why? Because in that way you can also know what type of prosthetic restoration you can do with your patients. And that's something that has changed a lot with time. Why? Because at the beginning when we started putting dental implants in the 60s with Albertson, we were just putting dental implants where we have bone. So we didn't care. Okay, you have bone, you have a little bit of bone, so we will just put a dental implant here. And then we tried to fix the best that we could with the prosthetics. So we were doing a lot of overdentures that were retained by dental implants because that's what we have. Now, we have improved a lot with the bone graft, right? Because in the 90s, bone graft material was way too expensive, so nobody was doing that much. Nowadays, because most general dentists started using it, we have a more demand from it. So now we can start putting more bone in our patients. So if we can do that, now we can put the dental implant when it's needed by your prosthodontic restoration. So we can just not do just function, but we can do aesthetics. Okay? So this is something that you will have to deal for the rest of your life. It's something that you need to remember because every patient that comes to you will be in the center, so you need to know where your patient is. So if a patient comes today and they say, oh, I have this tooth, completely bone reabsorption, you need to extract it, crown is completely destroyed, so you need to determine, well, do I make the extraction today and I put the dental implant today? Can you? Do you have enough bone? So you need to know if your soft tissue, your hard tissue is good enough for putting the dental implant immediately, right? So after you make the extraction, can you do that dental implant just immediately, right? The other thing that happens, sometimes maybe it's a little bit infected. So you make the extraction, you clean, you irrigate, but then you say, I can just make the implant placement just early. That means that we make the extraction today, and maybe 6 weeks later, we put the dental implant. So do you have bone after 6 weeks of extraction? No, not at all, never. But you have a soft tissue closure. So if that tissue is helping you to cover when you put your dental implant, now you can protect your dental implant. And if you need to put some bone graft, now you can protect it with that soft tissue. That's why we do an implant placement. Now, of course, there will be other patients that they maybe the extraction, they did it 5 years ago, 10 years ago. So now they come to you and they're like, hey, I have lost this tooth some time ago, what can we do? So now you know, well, you didn't do the extraction, but it was so long ago that now you need to know if you need to do some soft tissue management. It means that you need to check the soft tissue and you need to check the hard tissue. Because if you are missing both of them, that means that first you need to get back that bone and that soft tissue. And later on you put the dental implant. So you're playing with time. Okay? So we will have all those kind of simulations and situations, and all those kind of cases are the ones that we are going to talk about today. Okay, so the objective of today, so we are going to go with the trends on implant dentistry. So it has been since the 90s. Most of the times, of course, we use titanium. Of course, they need to be also integrated. And some of times, we try maybe to do one-piece dental implants, and other times we try to do early and immediate loading dental implants. But that's because patients, once that you make an extraction, they want to see something there. They want to have a crown, right? That's why it becomes really important. So since the earliest 90s, we have been trying to do non-submerged dental implants. That means that you put the dental implant and you put a provisional immediately. So we have studied that because at the beginning, what it means is, of course, if you put your dental implant and you cover and you suture, that's the old version. That's what you did last semester. You have a model, you put the dental implant, and you close, and you wait some months. So how many months do we need to wait for a dental implant before that we put a crown? Do you know? If you put a dental implant today, how many months do you need to wait before that you put a crown? Do you know? Yes or no? No? Okay, so what happens usually, right? You have already saw the presentations. So usually what you will have, if your day is today, that's time 0. And then what you will have is mode 1, 2, and 3. So if you put a dental implants today, when you will get it, if you put your dental implant today, it will attach to the bone, right? As we can see in the image. If you put your dental implant today, it will be completely attached to the bone. Does that have osseointegration? Is osseointegrated? No. But its whole is tight. Why? Because it has an extreme proximity with your primary stability, the first one. So usually at time 0, the old bone will hold it. But with time, it will decrease. Now, the new bone formation at the beginning, of course, is 0. There's nothing there. There's no osseointegration. So at the beginning, there's nothing there. But with time, we just grow. Okay? So we put this 2 here. So most of the times, when we started in the 90s trying to put early implants, we started putting dental implants just right at time 0 because we're like, oh, it's attached, it has primary stability. So we can put a crown because it's really, really tight. And then 2 months later, completely lost. Because we didn't know that, of course, osseointegration takes some time. And around month 2, you will have the least primary stability. The new bone formation is still not good enough. So if you want to put these dental implants and you want to do immediate implant, then that means that when you put the dental implant, usually what we do when we put dental implants is 35 newtons. That's how you put it last semester, right? When you were drilling your dental implants in your models, sorry. Okay, sorry about that. So when you put your dental implants also at time 0, you will put it with 35 newtons of torque. That's a really high intensity, so it gets really touched. So if you want to make this go higher, that means that you need to put it with 55 or 60. That's how we do immediate implants. If you want, you need to have a really good bone if you want to do immediate implant placement. Other way, it will always get lost. And that's one of the things that we have to learn in the hard way. Some patients lost some dental implants because we were trying to go from submerge and not submerge. Now, of course, we have been going with different type of dental implant companies. So most of the times we wanted to know, okay, if we put a higher torque and we put the dental implants and we just leave it exposed and we just put the provisional or the crown or the final crowns couple of months later, we will be okay. So we have done some studies, and we have found that you have had almost 98% survival rate, which is really, really good. Now, half of you already went to laser class, so you already know from Dr. Wang that it's still 98 is not good enough. That means that out of 100 patients that you have, 2 will give you really, really hard issues. And you will have to treat those patients, and they will be really complex. And we will do that in another lecture. We can see how to treat those patients. Of course, we have seen different type of studies, different type of approaches with different type of dental implants. The most famous ones, some of them has really low amount of patients in these studies, and other ones have really high amount of patients. But most importantly, we know that it works, because that means you can use different size of dental implants. The most important things that you need to use is a really high torque, otherwise you will lose the dental implant. So if you put the provisionals versus no provisionalizations, that means that you can do it, but you need to have a high torque. Now, the other thing that we have done also with different type of dental implants, the brain marks from the 60s, they were machine implants. That means that when you have the titanium tube, you just took a machine burn, and you just treat the surface. So it's a little bit rough. Why? Because the osteoblasts, the cells that create bone, they love rough surface. So they will get attached. So we will discover that. Then we start using different type of dental implant companies. They start trying with different type of roughness. We can do SLA activation, machine. We can have grit blasted. So that means that they will have, some of them were smooth, they fail completely. Other ones, there will be textures, because that means that we have added hydroxyapatite, we have blasted with other elements, we have changed the positivity and negativity of the titanium surface, and we have coated also the surface of these dental implants. We have tried different kind of things, and we get a really better osseointegrations. That means that there's more bone attached to the bone, and that's really important, because it means that in the long run, your dental implant will last longer. Of course, we have done some studies, right? When we put the dental implants, we were always screwing the crown to the dental implant. So some people started saying, well, in anterior it's quite difficult. There are some cases where it doesn't matter what you do. You put a dental small implant, really small, and your crown still is giving you nightmares. So, because why? Because if you have to screw, that means that your abutments and all the attachment and the screws are bigger, and they take too much space. And for an incisor or lower incisors, it's not going to work. So we start thinking about how if we start using cement dental implants. So we have done a lot of studies since the 90s, and we know that it works. But you need to be really careful how you use and you decide when to do it. Because there are some cases where you can have a really good occlusal balance. But we know from the screw point of view, the moment that you put a screw, that means that you need to make a hole in it. And that means that when you have those contact points in your occlusal relationship, you will lose those contact points. Because now you have a hole for your screw. So that means that when you put your screw, then you need to close it, and we need to put an OD there so we can have some stability. So that's really important, because it means that when you're making your provisionals, you need to choose where those contact points are going to work. And sometimes you can move them a little bit more mesial, a little bit more distal, or you can change the anatomy of the crown in some way that this screw can go a little bit more distal or a little bit more mesial, so your occlusal contact points still work, and you still have some balance. Okay? So, other ways, there are some cases where you don't need to screw, as we said. There are some cases where your bone is really thin, so you even manage to put a really small than mini implants, right? Less small than 3 millimeters. And even your abutment, you need to remove all the buccal side of your abutment all the way, you will never be able to put a crown. So in those cases, the old abutments were completely 360, completely circular. So the moment that you try to put the crown, it was going to be too bulky. So from an aesthetic point of view, not beautiful at all. So also the other things, usually most of the times, what we say, really, if you're talking in premolars and molars, what we said is that at least you need to have from the plate of your dental implants to the antagonist, you need to have 7 millimeters. That means that you have enough space for a crown to do. Now, will there be the crown 7 millimeters in height? No. But that means that you put enough space, 2 millimeters at least, for your soft tissue, and then you can make your crown that will be also holded by your abutment. Now, there are some cases, of course, some of your times you will find this. You will find patients that there are 5 millimeters, right? It's 5. So what happens? Well, if you have 5 millimeters, that means that you have enough space for a crown, but you don't have it for the abutment. Because the abutment needs to be screwed. So if you remove that screw, now what can you do? Well, I can cement the crown. So you can do it a smaller crown, but it needs to be cemented. Can you do cemented crowns in a first molar? You're doing fixed prosthetics, right? Can you do a cemented crown in the first molar? Right now you're doing provisionals and you're making crowns. When you make your final crown, it will be cemented to the tooth, yes or no? Right? So can it be cemented? Yes, of course you can be cemented for the dental implant too. There's no problem. The biggest problem with cemented crowns in dental implants is the cement. Because the moment that you put the crown, there's no periodontum that will protect your crown, your dental implants, sorry. So if you put a crown with cement, the cement will just go directly in. There is no periodontum there. So usually when you're in fixed, right, if you're going to put your final crown, you put what? Around your crown, around your tooth. If you're making a final crown and you will do final cementations, how do you protect the soft tissue around it? Do you protect the soft tissue around it? Right? So you need to put a cord, right, surrounding all the soft tissue in your sulcus so the cement doesn't go in. Otherwise, it will get irritated. If you don't do that, the moment that you put that cement, also your periodontal will be completely with an inflammation. So with the dental implants, what we can do is try to put the less cement that we can, or we try to make, this is a bone level dental implant. So what we can do is a soft tissue level dental implants, like the one that you put last semester. So where the crowns connect to the implants is a little bit higher than the bone, so it is easier to clean. That's one thing. Okay? And the other one is your patients cannot be with any parafunctional problem. So most of the times what your patient will have bruxism. So if your patient has bruxism, don't put some cemented crowns because they will fall down, they will break, they will give you some problems. So it depends on your patient. So if your patient doesn't have any problems, yes, you can put a cemented crown. But always you need to clean and make sure that you remove all the cement. All the way we will see what problem it creates, and we will see that in another lecture. Now, generally speaking, we will have some spaces. So most of the times, right, if you are thinking about a premolar area, that means that usually the diameter of your dental implant is 4 millimeters. But between your dental implant and your tooth, at least you need 1.5 millimeters away. That's when you put in your model last semester, you will way away from the canines and premolars, right? Then, if you are not experienced between dental implants, you need to have at least 3 millimeters of bone. So if you're experienced and you have a really good dental implant, you can use 2 millimeters. But still, I would not suggest you to do that, because if you do it less than 2 millimeters, what will happen to all this bone between the dental implants, it will be gone. Because most of the times, like, right? If you remember biological width from last semester, you know that your body will try to get that biological width. So all that bone will be gone and it will get full with soft tissue. So then we choose another dental implants, and then we have 1.5 millimeters. So the general rule of thumb, what it means is for each dental implants, at least you need 7 millimeters in width, always, because you need to have 1.5 to one side, 1.5 to another side. In general speaking, you put something that is 4 millimeters. So dental implants company will have 3.8, other ones will have 4.2, but generally speaking, that's just keep 4 as your main goalpost, okay? And 1.5 all the time. So the general considerations for dental implants, as we said, of course, if you are in lower incisors, you will have to put 3.2 millimeters. So if you have 1.5 to one side and 1.5 to the other side, at least you need 6 millimeters in width for each dental implant, for each central incisors that you put. Now, if you have a central incisor, anterior upper, and you put something that is as big as 4.7, it will lose your bone. The bubble bone will be completely gone, and you will have troubles. So most of the times try to put something smaller that mimics more the width of your root. Other things that we do, right, when we put your dental implants, some of dental implants, for example, for lower incisors, we can do one piece dental implant, so you have the features completely attached to the abutments, so there's no connections between them. Why do we do that? Because if you have a connection, like 2 pieces dental implants, that means that in that gap between the abutment and the dental implant, you can have cement going in, you can have bacteria going in, and that can create more bone loss. So there are some cases when you can use one piece and you will be completely okay, even better. Okay, now we can have different type of implants. Some of them, the connections inside will be hexagonal, other ones will be rounded, and depending on the dental implant company that you use, you will have that type of connections. The oldest one that we have is from Brainmark, from 3i, so it's an internal connections. So it means that the blue area that you can see that is outside, so when you connect the abutment, it will be attached to that part and it will not move away from it. Now, since the aesthetic issues, as I was saying, around 2006, we start considering that when we put dental implant, it was not just about the bone, it was also about the crown. So nowadays, what we do most of the times, we do what you're doing. We do the WhatsApp, we do the digital connections, so we know what most probably is going to be the final restoration. So the dental implants just follow that pattern. Now, because the digitalized kind of era that we have nowadays just follow the patterns of all the practices and all the studies that we have done in analog. So the kind of cases that we will show you today is old-fashioned, so you can connect with the type of practice that you're doing now in your lab and fixed prosthesis. So most of the times you will have a dental patient, so you can choose how many dental implants you will have. In some cases you can put 2 dental implants and you can with adjacent crowns. So sometimes you can just fix them. But you always need to respect the anatomy of your teeth, right? Because even though if you have a smaller central incisors, if you don't follow it, it will look crooked kind of effect, and that will make that prognosis of those treatments to last less. So how do we do it with anteriors? Well, if we have those two areas, most of the times what we try to do is to mimic the scallop shape, right, of the soft tissue with the papilla. So if we are going to make extraction today, most of the time it's better if all the bone is completely healed and you make an extraction that is okay, so you don't make too much damage to the hard tissues and soft tissue. We can put the dental implant and we can make provisional. Why? Because in anterior, the moment that you make your crowns, this is final crown, so you can make, but you can still make the provisionals and being attached. So the moment that you put the crowns, when they are provisionals, you remove all contact points in all movements. So in that way, you don't have any forces that can diminish or reduce the osseointegrations in your dental implants. Now, that's one way, because of course most of the time nowadays patients, they want to keep their teeth right, they don't want to be with a gap. So when you do this kind of approach, you need to understand your level for putting dental implants. You need to understand the kind of restoration, diagnostic restorations, but also you also need to understand your patients, the maintenance, and the selection. What does that mean? None of you have put a dental implant in anterior region, right? This is a really complex case. Don't do it. Okay? If a patient comes to you like this, send it to Dr. Juan, he can just put it, you can just show it, he can put the dental implants, and you can put the final crowns. Completely okay, no problem. So what do? You start putting premolars and first molars. When you have a lot of soft tissue, where you have a lot of bone, if it's not the perfect aesthetic kind of crowns, you can still fix it, and the patients will not have any problems. And when you're putting the dental implant, also when you're doing the surgery, it's an area that you can reach quite easily. So when you have done a couple of those cases, 10, 20, 30, then you can start going with these kind of cases. And if you're going to do it, start with a case, right? In this kind of case, patient is smiling really high, so we can see that the scallop shape. But there will be some patients that they have a low smile. So you can put a dental implant there first with a patient that doesn't need the aesthetic part. So once that you have done that, now that you have given some maintenance, now that you know how it feels to put a dental implant, how to make all the provisionals and all the final crowns, then you can start with a little bit more complex cases, but that will take time, okay? So I know that all of you love dentistry. I know that all of you, if you got into dentistry, it's because you will like a lot prostate. So you will enjoy this kind of cases. Okay, so, but be aware also of your skills. Can you get there? Yes, 100% you can, but it will take some time. So be patient. So also we need to choose the abutment that we are going to use. As we have been saying, that's really important, because once that we have put our dental implants, depending on the dental implant company that we will have different type of abutment. So that depends a lot also how we manage and how we plan to put a dental implant. So if it's a straight, if it's angled, or maybe when you're doing the surgery, it's not exactly as expected, and you couldn't use the surgical guide. So there is some angle there. So we can have different type of abutments. So we can have different type of impression techniques, and that's really important because you will get used to some of them. So we can see the easiest one. So what will happen? Well, if you put the dental implant today, right? 2 dental implants, you wait 3 months because those dental implants are completely covered. So what you are going to do 3 months later is to put a healing abutment. And you will wait around 2-3 weeks so that soft tissue heals around that healing abutment. So, and then you can take an impression for your final crown. What that means? Well, it means that we will remove the healing abutment, we will put that impression copy, we will take the impression, we will remove that impression copy, and we will put it in the stone. It looks weird, it looks a little bit complex, but I got you a video. so we can see it through step by step. So of course, each dental implant company, they will call it different, but the idea is, right, this we call it closed tray impression. So you remove the healing abutment, right? And now you put your impression copy. Okay, so you need to make sure that it's tight, not over tight, but make it that it's tough and it's tight. So when you make the impression, it doesn't come out, it doesn't move. So once that sometimes of course here you have a plastic, so it looks good in patients. When you put it, you take an x-ray. So you see that it's completely in place. In this kind of case, they have an extra material, right? So, but because we want to take care of the soft tissue and hard tissues, right? So we will have two different types of material. So we will use a light body, so that will be attached, and then we will use the heavy material, so we can make an impression of the soft tissue and hard tissue. Now, those posts each company has different type of shape, and that's the idea. It creates that shape that is unique in the impression. So we connect that post to an analog. The analog is just a mimic of your dental implant in your patient. So the post that you use in the patients goes inside of your impression, and the analog go inside the stump. Okay? And then you put back again your healing abutment. Okay? So this is the post that it was inside your patients. So you took an impression. So the impression will have the exact same shape of it. So if you put it, when you put it, you will feel that it fits. If it doesn't, then you need to take it out until it actually fits. And then this analog, it just mimic the dental implants, so that will go into the cast. So then you can remove it and you can start making your crown and you can send it to your dental technician. Now, that was a closed tray. Now we can do an open tray. That means the previous one, usually if you have one or two dental implants, that's a good approach, really easy to do. You don't need too much experience, and it will work really well. Now, there will be other cases where maybe you have 3 dental implants in one side and 3 other dental implants in another side. So that means that you need to be more precise, and you need to take multiple dental implants impressions at once. And that's is an open tray impression. Sorry. So in this one, we have an impression copy. We have the implant replica, which is the analog. So in this kind of case, of course, it's the same. You remove your healing abutment. You will put your impression copy. You make sure that it's tight. Once that you know it's tight, you take an X-ray to see if it's exactly in place. Then you can make its own curette for the patients, or you can just make the plastic one. You can make bigger space, because in that way you can make a space for each dental implant. You fill with a light body and heavy body. And now, from that one, you need to open the tube and you need to unscrew the impression copy. And the impression copy will stay in your impression. It will not move away. So if you have 2, 3, 4 dental implants, it's way more precise, it's way more complex. So at the beginning, I will suggest you to do closed tray, because that means that you're doing maybe 1 or 2 dental implants kind of approaches. Don't go to these ones until you have more experience, but eventually you will be able to do it. And then the last ones, of course, sometimes we will have patients that don't have any teeth at all, right? And we have complete dentures. So there are some cases we can make a post, or the dental implants company will sell it to you. So the post, you just screw it and it stays there. You don't need to remove it, because that post is the ones that will be attached to your complete denture. So you can take a direct impression to that post, and you can take it to your stone cast, you can make a complete denture, and then you can connect it to your post abutment. I will show you a case later on so you can see an example of that. Okay, so we can have different abutment installations depending on your case, depending on the materials. Usually I will suggest you to start, if you work really close with the dental technician, you can start working with the ones that they have, or the ones that are used by the same dental implant company. And later on, you can start going a little bit more complex, because some of the time they will do a screw or cemented. We can have a straight or angle abutment, right? There will be some cases that you will put your dental implants in, because you also follow where the bone is. Maybe you can go 3-4 degrees in one side. It's not the best one, but you can still fix it with an angle abutment. And then we can use a UCLA abutment. I will show you in a second. So most of the times, it's in the next slide. So in this one we can have, well, BioCare is external implant, is a screw. So there is a connection, and this space will create space for the soft tissue. So you will have a marking that where your crowns will sit, and usually most of the times, as we were saying, it will take too much space in buccal. So you can take a burn and you can remove all the buccal plate, so that will create more space for your final crowns. And that means that you have more material for your crown, so it will be stronger, it will not fracture that easily. And this is what you can get, you can see in the x-rays. So you will create a space and a scallop, so your bone is completely protected, and the crowns will just sit on that margin. So if you choose to use cement, as we said, you protect that space, you make sure that before that you sit it on, you clean the most cement that you can. Because always that once that you put them and you have excess, 1 week later that soft tissue will be red and will be a lot of inflammation. Okay, but that's for another presentations, we will deal with that. Okay, so we can have a straight or angled abutments, as we said, right? Of course, not all teeth are completely straight, and all patients don't have orthodontic treatment, so some of their teeth will be angled. That means that the bone also will not be the best one. So that means that we can use some angle abutments if we are making a fixed prosthesis or RPD, where we can do that. Nowadays we can do the CT scan of the patients. Now we don't use that much as done, but in your case you will start going from one to another one, or you can do some both type of cases at once. So when you're dealing with a 3D information, I think it's easier if you make your image in 3D. Most of softwares have it, so you can see the type of dental implants that you will put. All these software have all dental implant companies, so you have the exact size and shape that you will have, always see in all 3D, not just from the front or the top. Also angle the mandible or the maxilla, so you can see that the angulation that you have is the best one. So sometimes when you're putting your dental implants, right? So if you see upper left image, you have the higher bone in the center, but here there's a lot, 2-3 millimeters of exposure of that dental implant, right? Is that correct? Or is it wrong? Can you put the dental implant? We always say we need to put the dental implant inside the bone. We need osseointegration, right? But this part, the most coronal part, is completely exposed, and also for 2 and 3, 1 is just a little. And what that means, well, you also, when you put your dental implants, right, if you have adjacent teeth, you look at the CEJ, and most of the time from that CEJ, the top part of your dental implants need to be between 3 or 4 millimeters away from that CEJ. So if your dental implant is too high and is too close, you will not give enough space for the soft tissue. And if you go too low, because you're trying to put the dental implant all the way inside the bone, it will be too far. And your crown will end up being too large and too big. Okay? So what do? Well, you can put your dental implant there, and when you do the surgery, you put the dental implant there, and you put some bone graft, and you do some GBR or GTR. Okay? Now, because you have planned your dental implants, most of the software nowadays, what would you do, right, if you decide to put a 4 millimeters or 5 millimeters diameter dental implants? You will start for the smallest drill. Last semester, that's what you were doing in your model. You were putting different drills size, right? Until you reach the size of your dental implant. So it's the same here. You will start from the smallest 2 millimeters, 3 millimeters, 3.5 millimeters, and then you do 4 or 5. Why? Because if you start with this big one, and you put the drill there, you will be accurate, because you will be around the area where you want to put the dental implants. But the drill will get completely angled. So always, if you're using, always make sure that your preparations are exactly the same size of your drill. So in that way, you know that you're putting it in the exact place and also in the exact angle that you plan in the system. So we can have this kind of case. So as you can see, we have a really healthy teeth. Periodontally speaking, they are completely healthy, soft tissue. In this kind of case, as you can see, patients is brushing horizontally. So always make sure that your patients know how to brush better. But if you have a really good thick bone and a really good keratinized tissue, you can put your dental implants. So as we were saying before, in this kind of case, you see the drill is smaller than the preparation. So the angle is going a little bit too lingual. It's not exactly in the exact spot that you want. It's not bad, but we need to be more precise when we put the dental implants. Okay, so that's the entire idea. What is the also problem with this kind of approach? As you can see, when you're doing the drilling, even though if you activate your irrigation, the irrigation will hit on your surgical guide, and that's one of the biggest issues that we have with that. So it's really important that you drill the fastest that you can, and also every time that you go in, you need to go all the way out so that irrigations make the drill to get colder. Okay? So we have another approaches nowadays, so we have a navigation systems. We will talk that later in another presentation. Okay, so you put your dental implants pretty much close to what you're planning in the system. As we already know, that when we were drilling, if you have a D1 bone or D2, we will use a higher newtons, 55, 45, so it's really attached. And now what we do, we put a healing abutment there, okay? So the first day is patients, liquid, really soft, diet, smashed potatoes, chicken, right, fish. The first day you can just do cold things. The next day you can start doing kind of hot things. And that's for 2 weeks, okay? Most of your patients will deal with that because, of course, if they are trying to put dental implants, of course, they will also be concerned during the surgery, okay? So 1 week or 2 weeks later, you remove the sutures and you check that the soft tissues are completely okay. Once that they have healed, you can ask the patients to start brushing, and they can clean those healing abutments with the same with a toothbrush. If it's a soft bristles, if it's not, you can just use a gauze just to kind of clean the surface of these healing abutments. So once that we have waited, right, even though a couple of months, because at the beginning, this kind of case, patients, they are not biting. But what you need to make sure is that a couple of months later, all that soft tissue is pinkish, right, and you have a shape that can mimic what is naturally in your patient. Then we can already put some straight post abutments. So as you can see, not all of them are completely straight. So we can, it will be some problems. You will want to make a fixed prosthesis because, of course, the angle when you fix the prosthetics here is a completely different from the ones that you have here. We will see that in a second, how create some distortion. So when you make your provisionals, of course you do the wax up. Nowadays you can do it digitally and you can 3D print it. So you do the best scallop that you can. So you try to mimic the most that you can the shape. But of course, because the extraction has been so long, there's no way that you will make those papillas go really high. And because you have some space, 3 millimeters between dental implants, between the dental implants and your contact point should be around 2-3 millimeters of height. So you can make that scallop shape to go into that area. Besides, it's lower anterior, so there's no more difference. And then when you make your final definite prosthetics, when you see the provisional, you can change the angle of the tooth, and you can see that if you leave a little bit of cement of the crowns, or sometimes just by changing the angle of the tooth, sometimes patients will not brush the best way, so there will be some inflammations that you need to take care of it. Of course, this is what we were talking. Sorry, we put the slide later. So, UCLA abutment. Of course, you're making dental implants, right? You want to, if you have a case where you want to keep the papillas between, and you want to keep all that keratinized tissue, and it's a really aesthetic kind of problem, that means that we want to keep those soft tissues. Before, we didn't have CAD-CAM. So we needed a way to keep and push all that soft tissue just immediately after we put the dental implant. So the way that we managed, UCLA invented this really nice idea. So you have a plastic guidance, and onto that you can put some wax. So you can push layer by layer, and you can get really, really close to the area that you want to work with. So with that wax, then you can create your final abutment. So we can see in the other case, you will have you can just cut it in any shape you want, length or whatever, and then you can change, and you can put the wax, and you can try to mimic to the final abutment that you want. And if you think that you want to go deeper or higher or change the papilla, you can go more wax to one side or the other ones. Nowadays you have been doing that in your fixed laboratory. So once that you have the wax, you can just ask the dental technician, and they will just process this wax and make the final abutment based on that wax up that you did on your patients. Now, some of these UCLA, they are hex versions, so these ones are really active. So usually this one you can just use it if you are going to do, if your final crown will be a screw one, okay? So we only use this UCLA nowadays if we are going to do a screw final crown, or if we need to do a really individualized type of abutment, and you don't have CAD-CAM. If you don't have digital type of approach, then you need to do it old-fashioned way using a UCLA type of abutment. Now, if you have a non-hex type of UCLA abutment, you can just use it if you are doing fixed prosthetics, and if you are using anterior. And the same, if you cannot have a CAD-CAM. Nowadays, you can have a 3D system, so we can do it digitalized, so we can make an individualized abutment just based on the scan of the hard tissues and soft tissues. Okay? Now, in other cases, as we said, sometimes if you are not doing the best angle, and if you didn't use a surgical guide, this is what it will happen. One of your dental implants completely straight, the other one's completely angled. And what does that means is that if you try to put a crown on these two teeth, what will happen is that if you try to do a screw, the screw will go out all the way from buccal of your crown. So there's no way that you can do it. Okay? So that's why nowadays we try to do with those surgical guide, so you can get closer in a better angle, and if you have some problems, it are way smaller than this one. So in that kind of case, well, we will have to do a fixed prosthetic, and we can try to connect it. In this kind of case, we will have to do a really specific type of abutment for each crown because the angle of each one are completely different. And later on, we can do a provisional, so we can try to connect them the best that we can. So, of course, some of these abutments, as we said, we just remove completely all the local plate of your abutment, so you can fix your final prosthetics over there, and you can respect most of your soft tissue in the best way, and basically have a good oral hygiene. Now, in this kind of case, as we were saying, sometimes if you have your dental implants and they are way far from your contact point, this papilla usually will not grow into it. So what you have two choices. Or you make this contact point a little bit lower, or more cervical, 1 or 2 millimeters, so that soft tissue can feel it all the way, or you make entirely that contact point a little bit higher. Why? Because in that way, the patients can clean interproximally way easier. They can take an interproximal toothbrush and they can just clean. So sometimes you have to deal with that, and you need to discuss that with the patient. Don't let the patient know so they can decide what happens. It's their smile and it's their way of taking care of it every day. So the easier for them and the better for them, they need to make those kind of decisions too. Okay? So in other cases, we can have a really good keratinized tissue, so it will be really protected, so oral hygiene will not have any problems. But in these kind of cases, we can have an all ceramic type of abutment, so we can try to mimic the best that we can with the best materials that we have, all ceramic, so we can even give the best anatomy. So the final crown will last longer, will have a better thickness, and will have a better function and aesthetics. Okay? Now, full mouth rehabilitations. I just mentioned a little bit of those kind of impressions, but the first thing, the old-fashioned way, right? Patients came to you, you have a lot of problems, they tell you that they want a better smile, right? So this is why we got into dentistry. So you do a wax up and you make your crowns. Of course, all of you have been dealing with these crowns. Of course, with time you will get better. Nowadays you can use digital, you can use 3D printed, but there will be a lot of cases where you will have to do still old-fashioned because you want to do a more individualized type of approach where the anatomy also looks more to what the patient had before. So based on this, patients can be happy or not, and you can even decide. Once that you put this provisional, also it's good for the patients. If they tell you that they like it, then you can keep going with the treatment. If they don't like it, then you need to adjust the kind of things that they're complaining about. Okay, so when we do this kind of provisionals, we can decide how the occlusal status of the patients will be, conformative or reorganized approach. So the first one, we can try to mimic the good relationship that already exists between the jaws. So we just do some localized occlusal adjustment. Okay, so sometimes we just need to remove a little bit of the cusp. Sometimes we do some elimination of no working size of interferences. Of course, right now you are doing fixed prosthetics, so you already know what I'm talking about. Of course, the best ones that you can do sometimes is try to mimic a group function. And we have done some studies, and we know that we put dental implants in the canine area. If you use the canine guidance, the bone, you will have more bone loss around that dental implant if you use the guidance. So even if you have a single dental implant and you put your provisionals, everything goes smooth. So when you make the crown, you will make sure that the function will not be a canine guidance. It needs to be a group function so that the bone around that dental implants can be protected. Then we can do a reorganized approach. So in that kind of case, that means that we decide the entire occlusal scheme is modified. So we do what we think that is best for the patients, so we can have harmonious kind of occlusion. So we start with the occlusal relationship. So we deprogram the patients. Now there's some prosthodontists, they don't like to do that. But of course you need to try to keep the TMJ in the best place that you can. So even though that the alteration of the occlusion doesn't interfere with the complete seating of the condyles in the centric relationship. So if we do a full kind of restorations, of course in some cases you can just do dental implants. So of course you just follow those kind of patterns. You make the crown, so in the posterior regions you have the best occlusal point. As we said, no canines guidance. In anterior we can have the best balance. So after treatment we can have 500 crowns. So in some areas it's not the best seating, but it's a really good outcome. Patients can keep a good oral hygiene and patients are happy with their smile. So function is good, and then you just need to put a good oral hygiene and a good face for the patients. So that means that you need to give a really good follow-up for this kind of patients. Okay? So we need to adjust the long centric flow, follow the rules of anterior guidance. Of course, this comes all the guidance that we have for these full mouth rehabilitations are the ones that you're learning right now in your labs, because we just follow the ones, the old-fashioned ones that we will have for single or multiple crowns. So we'll determine the incisor H, refine the incisor H position, and of course, since some years ago, right, never proceed with construction of final anterior restoration until the patient is happy with the provisional restoration. So you will modify that provisional until they like the shape, and you take pictures and you talk with your dental technician, so that when the final crown is really close to the ones that they decided and they like. Okay, other cases we will have so full mouth rehabilitations, fixed prosthetics, so we can remove. Patients will come to you. You need to do a prosto approach, a perio approach. So that means that you need to take, right, as we have been saying for the last year, repeating all the time, take your patients, do some proving depth, see if they have mobility. If you have bleeding or proving, you already know how to diagnose your patients. So you first do that diagnostic and you treat your patients periodontally, and then you finish with your prosto treatment. Okay, so you treat the patients, you see the problems that already have been made, so you can remove those cantilevers. In the areas where you're going to do the pontic, you can also decide, in this kind of case, really deep pockets. So in some cases, we already know that the prognostic of the tooth are really low, so you can decide where you're going to put your dental implants. So the fourth thing, you take an impression. Nowadays, you can also do digital, and you can do a full WhatsApp of the patients, so you can check also the biting force, and you can do some adjustment, and with that one you can take an impression of it, so you can make an individualized type of thread for the patients. So in some kind of cases you will have to increase the size, because of course most of the time these kind of patients have some deterioration of their crown due to bruxism. So you need to adjust the size, and have the most harmonious type of impression and biting that you can. Of course, you will learn a lot of that within this year and next year, where you do full arch, complete dentures laboratory, and you will learn how to do this type of impressions and adjustments. Okay? So you can use prefabricated kind of crowns, but if you make them by yourself and you improve your WhatsApp, you can also make the teeth that looks more adjustable, individualized for your patients. Okay, so in some kind of cases, once that you have done it, you can adjust. Of course, the senates here are not the most harmonious ones, where the patient's smile is not that high. So what you're taking care of is how it looks more incisal, so patients will smile better. We can take a more adjusted type of impression, a light body, and we can do those through RPE that will be adjusted to the fixed prosthetics. So, and this is really important because it means that the crowns that we are doing, we just follow the same pattern. Dental implants, we just follow the same patterns that we already have from prosto. Okay, so patients will come to you, they will have 1-2 advanced periodontitis. You can do a removable partial denture, and maxillary implant with 10 partial overdenture, and a maxillary implant supported fixed prosthetics. So this will depend, as we said, a lot on your abilities as a dentist. Will depends a lot on the patients, right? Because sometimes they can have the money, but they don't have the time. So sometimes something that is easier and faster will be better for them. Or sometimes the oral hygiene is not the best one. So sometimes putting a dental implant is not the best option. Okay? So the first thing, of course, is to check hard tissues and soft tissues. So sometimes, even though if they want to put the dental implants immediately, as we said, we need to have enough tissue to put them. So in this case, yes, we have, it's likely just enough to put your dental implants. So in some cases, even though if you're going to make extractions, first you can put the first ones, and patients can keep those teeth so they can keep biting and functioning a little bit. And later on, once that you have made the provisionals, then you can make the final extractions of the remaining teeth that you will not keep inside the mouth. As we said, we can use a UCLA, we can make, here you have healing abundance, everything is clean, no inflammations, that means that we can move forward with the impression. So we can make, with UCLA, we can make a provisional. So this will just follow the same kind of approach that we will have with a complete denture. You will learn that next semester. So we try to mimic and adjust and get closer to where our dental implants are. So there is no attachment, they can fit completely okay, cannot be tight, and we remove and we adjust all the occlusal points that we want. Okay? There will be other cases where maybe it's not the best approach, or maybe you have waited too much, or patients sometimes they don't have the best oral hygiene. So what you will find is that some threads of those dental implants will be completely exposed, but the rest of the dental implant is completely healed. Okay? So in those kind of cases, it becomes a little bit complex, because that means that you already lost, maybe due to the healing process, or maybe not the best oral hygiene, is not infected, you clean, it's starting to be a perimucositis. So in those kind of cases, you can choose to clean with laser. In other kind of cases, you can take a round burn and you can just remove all these rough surface so it's completely smooth. So it's actually easier for the patients to clean. So sometimes you have to do in compromise, okay? And that's why it's important that sometimes you make your decisions with your patients before that you start putting your dental implant. Okay, so as we said, in these kind of cases, we are really, really close, but just exactly the minimum space that we can have dental implants, and on the other side, enough space between them. So we make a final metal structure, frame. We try always, we try that on the patients. You will always have to adjust materials. They modify because, of course, you are making high temperatures, lower temperatures, you are moving them, you are doing a lot of things. So in your patients, you need to always be adjusted. So once that you have tried it, then you can put your ceramic on it. In these kind of cases, yes, if you use retain, it will be so much better than just cemented. And of course, we can have, if it's splinted, dental implants can only be splinted if you have a reduced number of natural occlusal stop, steep anterior guidance, parafunctional oral habits, of axis angle implants. So there are some cases where you can splint the dental implants, but there will be other devices where you cannot do it. So if multiple natural occlusal stops, then you don't do it, you just use them one at a time. So you have a shallow anterior guidance, so you just put your crowns on just one dental implant, and or you don't include the canine guidance. Okay? So if you put it in one-piece dental implants, it can reduce the stress, and it can last long for a couple of years. And then we can have other kind of cases where we can have a complete arch edentulous patients, right? So in these kind of cases, of course, we need to always approach the aesthetic of the patients extra-orally. So we need to have a lip support and smile line. So that happens a lot. Sometimes patients have lost their teeth for a long time, for decades, for years. So that bond, the bond is completely gone. So sometimes we try to fix that with extra material in the complete denture. But one of the things that we can do also is to do some GBR, put some bone graft and some soft tissue, and that lip will go up and patients will look better. The smiles gets way better because the lip have more support than just with the complete denture. Of course, when you have, you can decide the number of dental implants that you're going to do. So we have different type of shape, right? All patients are completely different. So in some cases, we can have some square shape. In this kind of case, usually you keep your teeth if you are doing complete, right? All teeth are missing. So you can just do canines, second premolars and first molars. So you keep that anterior region out of place for your dental implants. So you just make a bridge there. Now there will be other kind of cases where the maxilla is not well developed. So in these kind of cases, you need to put 2 more dental implants and you put them in the central incisors plus the ones that we already mentioned. So you have a more stability for the patients. And then maybe if you have an oval type of arch for your patients, then in that kind of case, the same as the previous ones, canines, second premolar, first molar, and then you put an extra one in one of those 2 central incisors. So you can also create stability for the arch, patients can bite, patients can function, and then will work. As you can see, none of them reaches second molar. And that's one of the things that usually happens. Reaching second molar, putting a dental implant there is quite complex. Sometimes you will not reach, sometimes it will not be that easy. Most of the times it's really complex for a patient to have a really good oral hygiene there. So most of the times when you're trying to do this kind of complete dentures, always try to stay in first molar. Now, if the patient have a big maxilla, mandible, or you have the space, or patient had bruxism before, or there are some parafunctional activities, and you need to give more stability, right, or your bond is not good enough, then you can start thinking about that second molar, okay? But most of the tries not to do it. So we always focus on the aesthetics, the support, inter-arch, the space, right? Because that's the other thing, we have enough space. Because in this kind of cases, we are putting a metal arch, maxilla, mandible, plus the ceramic, plus the materials, plus the dental implants. So the space that you need to have, it needs to be really high. So in some cases, we can think about maybe putting 8 dental implants nowadays. We can try to approach in some cases. Now, nowadays what we have is all in 4, all in 6, all in 8, all in 9, all in 10. What that means is that you put all the complete denture, all the teeth, and of course, you put them in this kind of case, we can see 8 dental implants. But there will be some cases where maybe your bone in posterior is not good enough, and you can just put 2 dental implants in maxilla. Can you put all in 2? Yes, you can, right? So there will be some cases, usually the minimum that we say nowadays is if you're doing in maxilla, at least in maxilla, you need 6 dental implants as minimum. Okay, if you want to keep that complete denture with the dental implants. And in mandible, 4 dental implants to have a really good stability. If you put 2 dental implants, that means that you're just doing a complete denture that is just attached to those dental implants, so it has a better stability than by itself. Of course, all kind of fashion way. We take an impression, so we can have a heavy body and light body, and we can be really precise. You do the best WhatsApp that you can do for your patients, so you determine the height, and in this kind of cases is when you realize the size of your crowns. And if you need to add way too much tissue, that means that you have lost so much bone and so much soft tissue. So you need to, or either put it in your patients, right? Or you need to do extra material of your prosthetics. So sometimes you are way too angled anterior. We already spoke about that. So in this kind of case, you take your impression and you bring the analog with your impression. You can make your provisional, as we said, right? Sometimes it will be too much thicker, so because it's the minimum that we can have for the dental implants. Nowadays we have a smaller dental implants, so we can put more of them, or we can have more anatomical crowns. So in this kind of case, we will have our, we can run the material and we can make it with the dental technician, so they can make the final ceramic with the abutments connected with the space that it will match your dental implants, so you can have a really stable fixed prosthetic. So it's a screw retained provisional prosthetics, and then we can do our final approach. Now, with this approach, we're saying if you have enough bone and soft tissue, you will be okay. But if you have lost too much bone, that means that the lip in your patients will be completely down. Just putting this type of fixed prosthetics will not be enough. Sometimes you will need to do a complete denture because you have lost so much bone and soft tissue that just a complete denture can fix that, if you don't want to do the GBR right. So we take a reorganize our approach. So sometimes we need to adjust even closer and take a more precise type of impression. So we can adjust it in the lab, and we can do our final frame. And with that, we will have our final crowns that mimics the best that you can your crowns, and we can do our OD. So there are screw, but patients still can bite. And as we said, canine guidance, just group function. And in other kind of cases, right? Other case, we can have 6 dental implants. In lower, we have some cantilever. We put the dental implants. And in this kind of case, we can make just a grid for the patients. And we can have the space just open, so we can have, right, our impression copies. We can just attach them, so when we make impressions, they can come with your impression material and they stay in place, so there's not too much variation between what you got in the lab and the patient's status. Okay, so based on that, we can do the fake gingiva. With that, we can choose our healing abutments, final abutments, so we can create our crowns on top of them. Okay, so we do the scallop shape, and as we said, not too much scallop because the bone is not the best one, it's not that even, and we try to mimic the best that we can. In some cases, as we said, we create enough space so your interproximal toothbrush can just go in, patients can clean really well. It doesn't look nice, but it will be stable and healthy. So we can have some aesthetic abutments. These ones we can modify so we can determine where the margin of the crowns will finish. So as we said, sometimes they can go far away from the soft tissue. That means that the cement that you put your crown with will not go inside of your soft tissue. That means that it will stay healthy and it's easy to clean for you as a dentist when you put them, so you don't create any problems in the soft tissue or perimucositis due to the cement inside of the soft tissue. We can do the final frame, and patients will be completely healthy some months later. Of course, you always need to give some support to the lip. That's the main idea of this kind of approach. Patients can clean and it will stay in place. So we will have a bilateral balance with the opposite complete denture group function, as I just mentioned, and cement infrared occlusion and cantilever cement, it can just be 1 over 1.5 millimeters. That means that we cannot have too much cantilever. Other kind of cases, patients will just come, as we said, right? Sometimes they still have 1, 2, 3, 4 teeth, a little bit of them. We can check x-rays, we can determine, right? We have enough bone on the sides. This tooth will give you more problems if you keep them. We put the dental implants on the side and we can just keep those teeth just for the patients to feel good. But once that we have made them provisionals, right? As we said, nowadays we can do 6 dental implants on maxilla, 4 in the mandible, and that means that you will have a complete denture on that. Now, if the patients cannot afford, or patients don't like, or patient's bone is not enough, we can put 2 dental implants, usually most of the times in the canine area, so we can have a good stability, because the bone sometimes is not good enough, so when you make a complete denture, it will not stay in place. It's a hard time for the patients to talk, to function, to eat, so we can just keep those dental implants, and we can create a individualized abutment, and with that, sometimes we can have an extra oral resilient attachments, so sometimes we can have those ones. So we take an impression of those and we create or complete denture or partial denture depending on the patients, and they are just held by this ERA, right? So extracoronal resilient attachments. So what does that mean? It means that you will make your impressions, you will make your dental implants, so you will have this space with those impressions. So on those ones, you will put those extraoral resilient attachments, and to those ones, you will have this plastic ERA that will attach to that space, okay? So these plastic cups will just be inside your final prosthetics, and they will connect to that type of abutment. So usually these ones, if you have them after 5-10 years, they still work, but that means that every 8 months, every 10 months, you have to change them for the patient. So that's something patients comes, you remove them, you put the new ones, and patients can still keep having their complete dentures. Because of course, because this is kind, some materials are rubber, other ones are plastic, so they will just wear down. So we have other kind of cases, as we were saying. We have Chancon Memorial Hospital. They have different type of dental implants. So if you compare, you can see that you will have most in the posterior region is where they are putting more dental implants. So that's the kind of cases that I would like you to do. So in this kind of cases, you usually try to put different type of systems, but most of the times you will put one of them, the one that you learn, that you feel more comfortable as a dentist. And as we said, right, cumulative rate after 25 years, it will get really, really close to 100, but never will be 100. There will be always kind of cases where you will lose some dental implants. Okay? So also maxillomandible, pretty close the same. Usually maxillocs are the ones that will give you more troubles, but in this kind of case, after 10 years, there's still not too much difference. Okay? So barbell rate. If the longer that you put a dental implant, usually what we think is that you will have a better survival rate, and that's what we have found the most. So nowadays we try to put 4 or 5 millimeters diameter, and we put 8 or 10 millimeters in length. But that's why we have digital kind of approaches now, and that's why we have the surgical guide. Because nowadays we can try to push the most that we can, 10, 11, 12 millimeters in length. So the more the more length that you have in your dental implants, the better survival rate that you can get. Okay, so that's why nowadays, of course, usually we just choose the smaller ones because that's the kind of one that we have, but we should try to be putting a little bit of bone graft, or maybe you need to do in some cases, some sign of lifting 2-3 millimeters, and you will be completely okay. Nothing to do too much craziness. So after 10 years, 99% of osseointegration and survival. Of course, this takes long time to know. So of course, within maybe next 10 years, 20 years, patients will get live and they will have some oral hygiene problems, and this kind of things is what can happen later on. So it doesn't matter how much we talk about right? It doesn't matter how much we talk about dental implants, necessities, right? If patients don't come back to you, if they just escape, you could have spent hours and weeks to put your dental implants, check the angle that you can, the length, choose the dental implants that you want. You can choose the best material for your RPD, for your face prosthetics. It can get really clean and can mimic the best that you want, and you can mimic all the things that we talk about today. But if you don't keep your patients all the hygiene appointments, as we have learned from Perio, it will just be gone. You will just be lost some years later. Okay, so try to avoid this, and you will have a good practice, and patients will love you and will take care of them if they follow your guidance. Okay, thank you so much for your attention today.